Eloise is a nationally board certified licensed massage therapist with FSMTB and diplomate certified craniosacral therapist with the Upledger Institute International. Additionally, she is a certified presenter, teaching assistant, and techniques examiner for the Upledger Institute International. Eloise has defined and refined craniosacral therapy treatment protocols for those with EDS and continues to drive new techniques and adaptations for each of her clients. As an EDS patient and caregiver, she has spent years researching, practicing, and implementing craniosacral therapy techniques to specifically address the unique qualities of people with EDS. She's a lifelong student of her clients and in turn mentors and educates colleagues and health professionals on Ehlers-Danlos syndromes. So with that, I am going to go ahead and hand it right over. If you'll excuse me just a second, Eloise, I'm going to let the rest in and stop my share.
Sure.
Right.
Actually, Justin, I was wondering if you would set the poll up right now.
Yeah, this is perfect. Okay. So Eloise has asked me to start off with some poll just to get a little better number on some questions that she has for the group here within the Zoom. I'm also going to put a link for some handouts that will not necessarily be useful during the presentation here or the segment, but later on are going to be a great resource for you. I'm going to put those in the chat for everybody here. So right now I'm going to start the polls. This will give Eloise some ideas. You should see on your screen here. Let me just make sure I launched. Okay, I do. So the first one, have you heard of EDS? Do you have EDS? And are you a healthcare practitioner with EDS? All right, so I'll give it a minute or two. And I'm gonna put this inside the chat as well. And are you seeing the poll here on your screen, Eloise?
Yeah.
Okay. Perfect.
So numbers are still coming in, but I think this is kind of interesting. It's nice that most people, 83%, have heard of EDS, but some of you have not. So that's really great. I'll have an opportunity to share with you a little bit about it. The second question is, do you have EDS? And of the people here, 12 people have said yes, which is actually somewhat consistent with the general population of rare disorders of being around 10%. And those who are healthcare practitioner with EDS, 12% also have both EDS and are in the medical community in one way or another. So that's very interesting. So thank you. Thank you very much. I see a couple chats coming in. I wanted to say thanks for such nice welcoming committee. I'm going to close the poll. This distracts me, and the admitting button's a little distracting too. So I'm going to try and ignore those. So thank you. Thanks very, very much, Justin, for having me on. And I just want to take a quick opportunity to thank the Upledger Institute and, of course, Dr. Upledger for giving us these tools to be able to treat people. And let's see, I think I'll just get going here. And of course, my clients and my EDS community. So really quick, I came into the EDS world sort of by accident. I was already a craniosacral therapist, and my daughter started to experience really strange symptoms, and they just didn't really make a lot of sense. Long story short, she was diagnosed with Ehlers-Danlos Syndrome, followed by myself and my son. So I started to reach out to the CST community to find out what my instructors knew about it, and most of them had never heard of it. And so I started to embark on this lifelong process of implementing manual therapy and craniosacral therapy techniques to work specifically with people with Ehlers-Danlos syndrome. As a little premise to this presentation, there is a tremendous amount of information about Ehlers-Danlos syndrome, and I had to shave it down to some pretty basic things. So we're not going to go into deep detail on each and every one of the types of EDS and or all of the associated symptoms with it. So I'm sticking to the parts that affect us as craniosacral therapists and the work that we do with the central nervous system. Okay, just so you know. So let's get on with it. This is Dr. Upledger. For those of you who don't know, he is hero number one for me. I've got a couple heroes in this presentation. Second set of premises that I would like to express, especially to those of us who are here who are not craniosacral therapists, or those of you, is that we believe that there's an inner wisdom within ourselves, that inner wisdom knows what we need right now, knows what our history was, and it knows how to heal itself. It knows what it needs to do. We are literally, through our connective tissue, connected head to toe. There's no disconnect anywhere. And as therapists, we strive to meet our clients exactly where they are on any particular day, in any particular moment when they walk through our door. We don't have an agenda. We don't hold judgment. We try and leave our ego at the door so that we can be fully present with our clients. Many craniosacral therapists are trained and practice mindful lifestyles so that they can be the best possible therapist for you when you go see them. And the Institute itself, the Upledger Institute, has lots and lots of resources for us to be really good at that. Also, this information in this presentation is not meant as a substitute for medical care. We treat people, and we don't treat the alphabet. We're going to hear a lot of letters tonight, a lot of names, a lot of comorbidities, a lot of symptoms. We do not treat those symptoms. We treat the person who walks in to our office in whatever place they are at any moment in time and how they're feeling that day and what's happening. We treat the person holistically. We don't treat a specific symptom. So this is a handful of the things we're going to cover tonight. We're just going to go over briefly what are the Ehlers-Danlos syndromes, what we should know as craniosacral therapists, specifically to a few of the things in the central nervous system or the craniosacral system. And throughout this integrated, I will discuss how the craniosacral therapy can help, technique modifications, and how it affects the body. First things first, is it EDS or is it ED? It is EDS. The S is an important distinction, please. So please be cognizant of how you're using the abbreviation. So what is EDS? EDS is a collection of heritable connective tissue disorders. It's genetic. It's not autoimmune. It's not acquired. It's genetic. It affects the synthesis or the quality or the quantity and or all of the above of collagen. Collagen makes up most of our connective tissue, which is can be components of ligaments, bones, synovial fluid, all the encasement connective tissue for nerves and blood vessels, where some of the bones come together, like at the cranial sutures, the sphenobasilar base and the pubic symphysis in the ribs, tendons, cartilage, within the extracellular matrix, blood, lymph, cerebral spinal fluid, dentine, dental pulp. Those are all different types of connective tissue. They each have different percentages of collagen. There are 13 types of Ehlers-Danlos syndrome officially. This is a growing list. There are several types under review. So I am going to read these off. Starting at the top left, my pointer, get my laser pointer. Classical EDS, classical-like EDS, cardiovalvular, vascular, hypermobile, anthrochalasia, dermatosparaxis, kyphoscoliotic, brittle cornea syndrome, spondylodysplastic, musculocontractural, myopathic, periodontal. Those took me some practice to learn how to say some of those. You'll notice after each type, there is an abbreviation, a lowercase letter followed by EDS. That's consistent with the nosology of the categorizing, the labeling of what type is what. So if you come across a practitioner who's calling it by something else, especially the old numerical types that they used to use, like type 3, those are outdated by at least 5 years. So that practitioner may not be totally up to snuff on what's current. It is very hard to stay current because there's just changes every single day. Additional to Ehlers-Danlos syndrome is a suborder called hypermobility spectrum disorder. Hypermobility spectrum disorder came about because researchers, especially out of the Ehlers-Danlos Society, needed money to be able to research, especially hypermobile type EDS, and they needed to refine the diagnostic criteria. So they made it very narrow, very specific, and very strict. That tended to leave a number of people out of the diagnosis of hypermobile Ehlers-Danlos syndrome, but place them into hypermobility spectrum disorder. So some of the hypermobility of the body, and we are going to talk a little bit more about that, don't worry, isn't necessarily as severe. However, most people with hypermobility spectrum disorder have all of the same symptoms, have all of the same comorbidities. The treatment is the same. The response to physical therapy and manual therapy is the same. They still will have joint injuries, and they still may very well bruise easily and have other issues with their skin or bleeding. So it's important to understand that there's this other spectrum, and it is a spectrum, but and it is under review right now. So the EDS Society realized they might need to take another look at this. I just want everyone to know that. So to keep your eyes open for further information coming out about this. Collectively, all 13 types of Ehlers-Danlos syndrome are about 1 in 5,000 people. However, some of the types are found in less than 1 million people, or maybe just one family. And that's the most rare. And then the more rare of the the more common of hypermobile type would be about 1 in 250. It is considered a rare disorder, and hypermobile type in particular is often rarely properly diagnosed. So it still maintains its rarity. I got an email yesterday about some researchers who were looking for some information about financial burden on people with EDS. And they were basing their research on a previous research study by Every Life Foundation for Rare Disorders, which did this study of 379 families with rare diseases to find out what the financial burden was for them. And they learned that in 2019, this test was done in 2019, there was a $1 trillion financial burden on families with rare disorders. I think that that's alarming, and I'm just bringing it up so you understand that it's expensive, you know. So if as a therapist, if you can, I'm humbly asking that you offer some kind of sliding scale to your clients with EDS. They greatly appreciate it. All right. So because Ehlers-Danlos syndrome is a connective tissue disorder affecting collagen, all of the systems in the body potentially can be affected, and most oftentimes are in some way or another. The severity of presentation and how people are experiencing their Ehlers-Danlos syndrome can vary widely, and you can find people who are still very active and athletic, even, and some elite athletes have Ehlers-Danlos syndrome. And you have on the other end of the scale, you have people who are completely debilitated by it and cannot even get out of bed. Oh, I missed one. Also, there's no cure for EDS. Care is given through management of symptoms. One thing I also want like you to know is that because there can be this huge variable in severity, a lot of people with EDS will experience a type of gaslighting from the medical community, or they're straight up abused or neglected. Some common things I've heard people tell me is that they've been told by their physicians, you're too young to have this. Why would you want this? It's too rare. There's no way you can have this. Nobody has that. I personally was told by a doctor in front of my daughter, he said this to my daughter, it's not painful. And that's just simply wrong. Other people have said, just exercise more and drink more water. All of these are a way of gaslighting a person into thinking that their symptoms aren't valuable. And this is something I want to make sure we're not going to do as therapists. When a client walks into our office, we're going to listen to them and we're going to hear them and their story. So cardinal signs of Ehlers-Danlos syndrome are joint and skin involvement mostly. There are a lot of things that happen, but with the skin, we can have this atrophic scarring, which is if you have an injury to the skin and it stitches itself back together and heals, there might be kind of a pitting to it, or it could look like tissue paper or cigarette paper. The skin can be very mild, can be very stretchy or mildly stretchy, depends on the type of EDS. And also the skin involvement depends on the type of EDS. It can be severe, it could be mild for the scarring. There can be easy bruising. It could feel kind of velvety and soft. It has a delicate feel to it. It can tear easily, and some types of EDS, it can look translucent. Like you look right through it to all the veins. This is just another schematic to just show that all the systems can be involved, and all the way down to the teeth, where we have periodontal ligaments that hold our teeth into the bone. And the periodontal ligament is made of collagen. And well, if we have a collagen disorder, we may very well have difficulty having our teeth stay in the socket attached to the bone. Joint instability is more than just hypermobility or double jointedness. It is joint instability as well. There can be some spinal curvatures. I already discussed the skin issues. There can also be an overlapping history of blood disorders like hemophilia. Allergies are prevalent. MCAS stands for mast cell activation disorder, which is a hyperactive allergy. It's very complex, and I'm not going into detail on MCAS. Neurological manifestations and dysautonomia. I am going to talk a little bit more about that. Cardiovascular abnormalities in structure and function. There can be valve problems or aortic root dilation or aneurysm. Gastrointestinal issues. And then additionally, there can be some more severe issues that happen. One can be an organ rupture. So like the bladder can rupture. Vascular compression syndromes. One I'm more familiar with is called medial arcuate ligament syndrome. It's where the diaphragm it rides a little low in the body and puts undue pressure on the celiac nerve plexus and the celiac vein, and that can be very painful. And then there can be surgical complications, including anesthesia. So in dental procedures, local anesthesia may not take. And in general anesthesia, there have been reports where people wake up during surgery. So of this list of things, we're going to go a little bit more into depth on the neurological manifestations, a little bit more on dysautonomia, but not too much, and a little bit in joint instability. Before I go into that, though, I have some other foundational pieces to lay down. So there are some physical features in Ehlers-Danlos syndrome. They can be tall and slender or short and curvy, but that doesn't really matter. There can be a high, narrow, arched palate. So all of our work that we do intraorally, that intraoral work can help affect this high, narrow, arched palate. With that comes crowded teeth and gum issues. There can be pectus excavatum or carinatum, which is a condition of the sternum that is either excavatum, it looks like it's caved in, so it's sunken into the chest, and carinatum is when it's sort of pigeon chested, when you're outward more. Long, slender fingers and toes, flat feet and pronated feet, scoliosis, and the sclera of the eye, that white part, can look blue. And there can be abnormalities in the cornea itself. This is my friend Dawn, and I have her permission to share this picture. Thank you, Dawn. Dawn is sporting all of the braces that she has. So this picture was taken a few years ago. I'm going to use my magnifying tool, and I'm just going to slide up here. I want to show you guys the ring splints. So she has these really fancy, beautiful silver ring splints that help keep her fingers from hyperextending and dislocating. And she's also wearing a wrist brace, which covers her thumb. So it's a wrist and thumb brace combination. She has a neck brace, 2 knee braces, and an ankle brace. This picture she sent to me today. This is another piece of equipment that she has, is her service dog, Irving. Irving is a phenomenal dog. Most service dogs are just absolutely phenomenal, and they blow my mind. One thing that I learned about service dogs is that they're considered medical equipment. So just like the braces or crutches or a wheelchair, a service dog or service animal is considered medical equipment. So you would never, ever take someone's crutches away from them and tell them to walk, or take their wheelchair, or remove them from their oxygen, right? You would never, ever do that with their service dog either. They're not to be separated from their handler. If you see one out in public, you stay away from it. Don't touch it or talk to it. It is working. And if it's distracted, it can't provide the job it is trained to do for their handler. That's just a little on service dogs. I understand this image might be a little difficult to read. I hope it's not too bad. This is part of the handouts that I am providing to you. Those handouts are going to be available on my website. This is the list of the Ehlers-Danlos syndromes. The top left, the left-hand column is the name of the EDS. The middle column indicates if it's autosomal dominant or autosomal recessive. If it's an autosomal dominant gene variation, you just need one parent to pass it down to a child, and there's a 50% chance of passing it down to the child. It does not matter the gender of the child. It's just 50% goes down. So that's all male and all female at birth. Autosomal recessive. So the AD is for autosomal dominant. The AR is for autosomal recessive. We need both parents to pass down gene. Oftentimes, if those genes, if that child inherits the disorders, autosomal dominant or autosomal recessive, they will present with symptoms. It's not going to be hidden. If they're just, if it was an autosomal recessive gene passed by one parent down as one gene of an autosomal recessive trait, then that child might be a carrier and may not present as severely. Third column is the gene specifically involved in the type of EDS. And in the far right column is the protein affected by the gene mutation from the genetic basis. Okay, so this is how you would read this and how you could try and understand what you're looking at. You'll notice that the proteins involved range from type 5 collagen, type 1 collagen, type 3, down to something that doesn't look like collagen at all. It says atom. Okay. So it's an interesting ride to go read about these in depth. There can be multiple pathways for certain types. So classical EDS has 2 pathways. Vascular EDS has 2 pathways. Kyphoscoliotic EDS has 2 pathways. Brittle cornea syndrome has 2 pathways. Spondylodysplasia has 3 pathways. And musculocontractural has 2 pathways. Clear the slate. Back to this. Hypermobile type EDS, autosomal dominant with no known gene or protein involved. We just don't know. Unfortunately, it's also the most common, and it's the most misunderstood, misdiagnosed, and undiagnosed of all of the types. And it also is usually the most systemic. There's a laboratory called Norris Labs that is hot and heavy into doing research and finding the genes responsible. And they have not been able to release anything official, but their research is leading them to learn that there is a problem in the extracellular matrix, which is the soup where all of the building stuffs are present to be able to put the fibers together for collagen. So they're finding that there's a hiccup in the actual components of making it. So collagen is the most abundant protein in the body. It is responsible for the structural stability in all of the systems. It is made of 3 amino acid chains that form together, they bundle together to form a collagen molecule, which bundle together to form a microfibril, and those bundle to form a fibril, and those bundle to form a collagen fiber. Okay. Vitamin C for this process is an absolute requirement. Without it, collagen can't be built. And incidentally, vitamin C is a mast cell stabilizer also. So it helps to control the mast cells. We are going to talk about mast cells later for a little tiny bit. I came across this image a couple of years ago, and I found it to be really quite fascinating. This is a photomicrograph of dura showing collagen and how it is laid down for collagen. In particular, it is a section of the dura that includes an arachnoid granulation, which is the structure of the dura that helps to reuptake cerebral spinal fluid in the brain. Of the dural, it's a specialized section of the dural layers. Try and keep it simple. So here is the dura itself. Okay, it's a very longitudinal, kind of horizontal. It's really horizontal layers, and then it blends into the arachnoid granulation, which becomes more mesh-like. I find this to be fascinating, and I also find this to be important in that, again, if we have a collagen disorder of the body, how might that be affecting the reuptake of cerebral spinal fluid? Does it make a difference? If it does make a difference, how is it making a difference? Is it possible that intracranial pressure can't regulate very well if the collagen is lax? And can the collagen be lax everywhere? I'm sorry, the dura be lax everywhere because of a lack of structure of collagen. So we have a fundamental difference in structure. I think we need to have a fundamental difference of approach to care and approach to our manual therapy, while still also respecting the inner physician and the body of where it is in time and space. And in that moment, like we talked about before, we meet the person where they are. So structure follows function. This is one of the tenets of craniosacral therapy. Structure and function are inversely related. You cannot have one without the other. So if your structure is not strong enough, then function becomes impaired. If your function is impaired, then it becomes dysfunctional. If you have a dysfunctional area of the body, then the structure around that dysfunction is going to hug it. So Dr. Barral has a phrase of the body hugs the lesion. In this terminology, lesion is an area of dysfunction. Okay, so if the body has developed a dysfunction because the structure is not strong enough, then it's going to have a hugging around that more and more, and then structure now also becomes dysfunctional, and around and around and around we go. So we need a little bit of a paradigm shift in how we think about treating. So in normal bodies, that's a terrible way of putting it. I'm so sorry. So in people with normal collagen, muscles are joint movers and they are meant to be somewhat elastic. Ligaments are joint stabilizers and they're like iron bars. Okay. Got that? Muscles are elastic. They move the joints. They're meant to be pliable. Ligaments are meant to be very strong and stabilize the joints. Some muscles help with that job, but mostly they're there to move the joint. In Ehlers-Danlos Syndrome, the reverse is true. The muscles become like iron bars because the ligaments are like stretchy rubber bands and they cannot hold the joint together. So the muscles start to lock down and hold everything in place. Sometimes we even see other instances happen where bone starts to form to help stabilize a joint, like in arthritis of the neck, or another condition called Ehlers syndrome, which is a calcification of the I forgot the stylohyoid ligament, which goes from the base of the skull to the hyoid, starts to calcify. It looks like big spikes in the neck. And some theory is that it becomes that way to stabilize the neck from hypermobility. So we have a double-edged sword. We have ligament laxity, which leads to muscle compensation, which they become way too tight, which can pull on other joints, which changes stability in other joints, maybe further away, and misaligns the body, which can cause more instability again and again and again. Okay, and the body continues to fight itself. So our goal in manual therapy really isn't to remove all the restrictions and soften the body, but it's to improve stability and balance the tension. So if there's too much tension on the right shoulder and not enough tension on the left shoulder because it's lax, it's slipping out of joint, perhaps we can do some gentle manual therapy in craniosacral touch very lightly to bring balance to both shoulders so that one isn't pulling the other one out. This is hero number 2. This is Jean-Claude Jambertu. He is a surgeon and he decided he was going to videotape fascia during live surgery. And he got down to these teensy tiny, very finite areas of the body and looked at fascia in a way that no one else has. And he's demonstrated how three-dimensional it is. It's not just wrapping up our body with fascia, which is what I was taught a long time ago. It was just a covering. It's so much more dynamic than that. Jean-Claude Jambertu has a book called Architecture of Human Living Fascia. It's one of my favorite books. And in the bottom right-hand corner, it's just a little bit of a graphic that shows how connective tissue is from the skin to the bone. It's one continuous piece. It has different densities, but it's still one continuous piece. So because of his work, I've been able to see fascia in a different way. And I now see that every tissue is a derivative of fascia. And like I said before, it ranges from very dense to very delicate, and it's continuous. So even as we are developing as babies in utero, we don't start out with our bones first and then have everything wrap around it. We start out as connective tissue in some manner or another, and those bones and organs and muscles and tendons and ligaments and cartilage grow out, and our central nervous system grow out of that. So what should we know? There's a lot we should know. I'm going to go through a few things, a few. So because hypermobile EDS is the most common EDS, it's the most common type of EDS that we have, that we know of, that is what I'm going to talk about. So like I said before, it's about 1 in 250 people, and most likely to see it in your practice. There's some diagnostic tools that can help you. One's the Baton, next one's Brighton, there's genetics testing, and there's clinical presentation. The Baton score is a score of hypermobility. It's a score of 9 points. You get 1 point for each thing you can do, and that is bring your pinky more than 90 degrees in hyperextension, your thumb to your wrist and a hyperflexion of the wrist. If both elbows hyperextend when you straighten them, and your knees as well, hyperextension. And then a flat if you can bend over in half, put your hands flat on the floor. This is hero number 3, Sabia Malik. Sabia Malik has written a couple of papers that I'm following. I've read and I follow her. My favorite paper that she wrote was a challenge to the Baton score. And I have maintained for the last 10 years that that Baton score is not sufficient to help us with understanding the full extent of Ehlers-Danlos Syndrome, because it does not take into consideration instability and hypermobility of shoulders, hips, ankles, the spine, the sacrum, the neck, etc. So Sabia has challenged the Baton, and she wrote a great paper on it. And the other paper that she wrote is a theory on pathophysiology for EDS. And the title of her paper, which I'll put also up as a resource on my website, is the role of cell adhesion and cytoskeleton dynamics in the pathogenesis of Ehlers-Danlos syndromes and hypermobility spectrum disorders. So that was a lot. That's why it's not on the slide, the whole title, but there it is. She's a rising star in our community. So the Brighton score breaks down a couple of other just everyday questions. Do you consider yourself double jointed? Can you now or could you ever place your hands flat on the floor without bending your knees? Can you now or could you ever bend your thumb to touch your forearm? As a child, did you amuse your friends with contouring your body into strange shapes? Or could you do the splits? And as a child or teenager, did your shoulder or kneecap dislocate on more than one occasion? And then this is the Ehlers-Danlos criteria, diagnostic criteria for hypermobile type EDS. I do know that this is hard to read. I am going to have this also on my website. So there's 3 big categories. So you would, to have a diagnostic criteria, and it's a clinical diagnosis. It's not one done with genetics because there's no genetic marker for it, but you have to meet generalized hypermobility scale, which is age and sex linked. So depending on your age and what gender, you have a different scoring criteria. You have to have 2 or more from the second category, and there's 3 subsets in that category. And then you have to meet all of the criteria of the last category. This is new. This is called the spider scale. This is somewhat in development, but the Ninus Wandil and let me see, Ninus de Wandel and I. Simmons, and sorry, I probably didn't pronounce those very well. They created this subjective spider scale so that when patients come in, they can rate on a scale as this what their severity is. So the center of the circle would be like 0 on a pain scale, and the outer edge is a 10, say, okay? And so then a patient can mark along the line on any given day where they are in their symptoms for that day. I believe that something similar like this has been developed for diagnostic criteria too. When we treat, we just need to know a few things just to be careful. We don't want to do a lot of motion testing with people with EDS. They're hypermobile. We don't need to test how much more mobile they can be. The technique that we've learned in craniosacral therapy called regional tissue release often invites the joint to move into places that it wouldn't typically go so that it can release a restriction within its joint. But in EDS, we would not want to allow, in that particular technique, we would not want to allow that joint to go into its full end range and have it try and go further. That may very well damage the ligaments further. And then meeting barriers in the body. If you are able to feel the barriers in someone with EDS, you want to just not stay very long with them and use much less pressure. So we're talking 1 to 2 grams of pressure instead of 5 grams of pressure, which is the standard. So standard within reason. And there are some global contraindications straight out of the gate. End range motion. Like I did mention this just a moment ago. And the other is the OCB platform, which is step 3. This is the occipital base platform. There are a couple of Ehlers-Danlos specific contraindications. So there are some comorbidities of Ehlers-Danlos syndrome that will be a problem if they want to try and get craniosacral therapy. One, and this is this list: syringomyelia, aneurysms, an active cerebral spinal fluid leak, stroke, or uncontrolled intracranial hypertension. And then there are situational and technique contraindications. Other things that can be found fairly commonly in EDS are Chiari-1 malformation, tethered cord syndrome, and craniocervical instability and atlantoaxial instability. I am going to go into these in a little bit more detail. So the technique contraindications, dependent on the presentation of your client, are for Chiari, inferior dural tube traction, cranial compression techniques, direct pressure on the occiput, and still points. For tethered cord, dural tube traction, contraindicated. And for craniocervical instability and atlantoaxial instability, this is instability of the occiput to C1 and the C1 to C2. Contraindications include myodural bridge release, if you know how to do that, any motion testing of the cervical spine, and the OCB platform. And also OCB platform under Chiari. But again, that is a global contraindication for for EDS. When you see a patient, please take an intake. Please take a nice, thorough intake. People with EDS have very complex medical histories. And the more you know, the better. It is the best way to flag for any central nervous system comorbidities that might affect your craniosacral therapy treatment. Headache is common, and headache can be caused by a number of those neurological comorbidities. So please take a headache history. You might be able to flag somebody who may have Chiari and may not know it. Okay. And then ask questions about the nervous system. Ask how their digestion is. Ask if they have any cardiopulmonary issues. Okay, try and get a nice, good sense of that. I find that with the SQUAR, our craniosacral SQUAR, which is our evaluation tool for how vital the craniosacral system is, which is symmetry, quality, amplitude, and rate, that symmetry and rate are about average. Amplitude can be low. It does just the range of motion and amplitude is not as wide as it could be. So both the flexion and extension in our assessment will feel very narrow. It can feel very narrow. The rate varies. It varies from average to way above average really fast. And when I find that it's the person is in this high sympathetic tone. They're in fight or flight. And the quality of the craniosacral rhythm is smooth and it's delicate and it's fluid, and finding restrictions within it can be very difficult. So finding a restriction in somebody with Ehlers-Danlos syndrome, I have tried so hard to find just the right way of describing, and I have come to, feels like a cloud. It feels like I'm trying to find the edge of a cloud. So we not only want to use even just that touch, like if you want to try and find a barrier and feel into the tissue, try to feel like it would, try to feel it like you were trying to feel a cloud. The other would be mist. Okay, just so delicate and so light. And where would you have to be in your body and in your hands to be able to feel such subtle changes? Our touch doesn't need to be very big. It just needs to be a couple grams. The easiest way to feel into this also is just be grounded as much as possible and be patient. The body may feel very different. The subtle shift in tissue and perception. So every change in the body is going to be delicate. It's going to be subtle. So you have to be able to reach into that and feel that so that you can perceive it. Any change might be very rapid and it might go further than you expect it to. So be deliberately gentle with your touch and approach. So now, Justin, I feel like I'm like running really long. Are we still good on time?
Yeah, I mean, let's keep it moving for sure. I don't want to cut you off.
Okay. All right. So maybe we'll just do one of these. I have a couple of little palpation skills. So if you guys have your toilet paper, what you're going to do is you're going to tear off 2 or 3 squares. Okay. Now get a sense of the palpation that you need to have to feel into the body of somebody with EDS and change any restrictions that you might have. That touch is going to be, if you can just get your toilet paper and you can put it down on a flat surface if you want, or hold it up like me. But I think a flat surface is better because you can put your hands flat on it like you might a person's body. And you're going to approximate the tissue apart from itself. So you're going to pull left and right, pull away, pull the tissue taut. Okay. And just in that very moment where the perforations start to separate, just barely, and that's the pressure you want. Okay. That's the kind of pressure you want. And that's the change you're looking for. It's almost nothing. And now I am going to move on to one other one. Now, if you take that same tissue, it should be 2-ply on purpose. And you separate the 2-ply, but don't do it too fast. You're going to do a little bit at a time. First, get the edges separated. Okay, get the edges separated. And then you can lay it flat on the table also. Okay, and you're going to very, very, very gently start to separate these out. Go nice and slow. This is something you can also practice at home on your own, whatever. Where the tissue is catching and then releasing, catching and then releasing. That is akin to how somebody with normal collagen would feel, especially in the dura. Somebody with EDS, this little bit of catching and release might feel more like a melting, like if you had cotton candy and it just was just melting away in your hands. That might be the difference for you. Okay. And I'm just going to describe this for you. The palpation that I use, you don't have to do this, but the palpation that I use when I know I'm done in an area with the tissue, it's like a clicking into place, like Velcro. So if you have your Velcro and just barely connected the 2 edges, connected the 2 sides together, and in that exact moment where they come together, take note of how you know that without looking at it. How do you know that? Where is that in your body? That is the tool you're going to need to work with somebody with EDS. So where is that? How do you feel that? For me, it feels like there's all of a sudden like a little click, a little magnetic connection. There's like your shoes on exactly right, you know, or the soup that you're making has come together perfectly. And you just know it's perfect because of how it feels and how it tastes. It's comfortable and it's subtle and comfortable. I asked you guys to get cookies. I'm not going to do the cookie experiment, but you can eat them now if you want to. Okay. So Justin, I do have a bit. You still want me to go?
Yes.
Good. Okay.
Here.
All right. Let's roll. Okay. So joints. We have 360 joints in our body. So each one of those areas is a vulnerable area of injury. There's an increased range of motion in these joints and hypermobility. And because of the ligament laxity, we can have subluxations and dislocations and soft joint injuries very, very, very easily in people with EDS. So what does that do? That increases the pain. And pain can be either acute if it happens suddenly, if there's a subluxation or dislocation all of a sudden, that can be acutely painful. Or having many of those over time, pain can become chronic. Pain is the #1 symptom and problem in people with EDS. Common subluxations will be in the circumferential joints in the shoulders and hips, more the shoulders than the hips, but a lot of people have problems with their hips. The hinge joints, like your knees and your jaw, and the ribs. This is a long list of the central nervous system comorbidities, and this isn't even the full list of this list. I want you to notice this is the central nervous system. Now, it looks an awful lot like our craniosacral system, right? That's pretty much almost the same thing. So of this list, we're going to review Chiari, tethered cord, craniocervical instability, and atlantoaxial instability. A Chiari is herniation through the cerebellar tonsils and or the brainstem through the foramen magnum. So there's increased pressure on the brainstem and spinal cord, and reduced intracranial space for cerebral spinal fluid, the cerebellum, and the fourth ventricle. There are a number of symptoms, which would include headache, dizziness, balance issues, visual disturbances, fatigue, pain across the shoulders and neck, breathing issues, trouble swallowing, and be numbness and tingling. This is what a normal brain is supposed to look like. You can see this is the cerebellum. This little nugget right here is a cerebellar tonsil, and this darker gray is cerebral spinal fluid. You can see how nice and high the cerebellum and cerebellar tonsils are. Lots of space for cerebral spinal fluid. This is the clivus of the occiput. That's this section, this sort of sloping section in the floor of the skull, of the occiput itself, where it meets the sphenoid. The little block in front of that is the sphenobasilar. Oh, the little line there is the sphenobasilar junction, and then the block is the sphenoid. The hook in the back is the occipital base, and the space between the clivus and the occipital base is the foramen magnum. These two little pieces are C1. Lateral ventricles 1 and 2. This image is probably only showing you 1 because it's a sagittal slide, slices the body right down the middle. Third ventricle, fourth ventricle, in that space. In this space is this fourth ventricle. This is the pons, the medulla oblongata. And then this is an image from Netter, kind of blown up to show the cranial nerves with the pons and medulla oblongata, and a little bit of an overlay of how they all come together. So I know it might be a little challenging to see, but these red and blue lines are cranial nerves, and the fourth ventricle is right here within this blue triangle. And you can see if there's crowding, it's going to impact the cranial nerves. The straight sinus and the tentorium cerebelli are something that we learn in our classes. The tentorium cerebelli is also called the horizontal membrane system. And we can see that here in this image. The tentorium folds in on itself to create the straight sinus. So that is why they are together. This is the dens of C2. This is that peg of C2. C1 rotates around it. And you can see it here. This triangle piece is the dens. And then this is going to be Chiari. So on the right, you can see that the cerebellar tonsils are hanging fairly low. And in fact, they've come below the foramen magnum, which is the red line. And crowding cerebrospinal fluid. The fourth ventricle has some CSF in it, but it doesn't have the same amount of space. And so these cranial nerves are going to be affected. Also, here's the dens of C2, and you can see it's bent backwards a little bit. That's called, oh my goodness, that was right on the tip of my tongue. Retroflexed. That is a retroflexed odontoid, another name for the dens. On the right is a more severe Chiari. It's way past the foramen magnum. And this is an image of syringomyelia, which is buildup of cerebral spinal fluid within the spinal cord. It causes pressure from the inside out. This is completely contraindicated for craniosacral therapy. This is also often found with people with Chiari. So if you have a client who has Chiari, and they know, you have got to ask them if they have an associated syringomyelia, often also called a syrinx. Surgery is usually what they do for Chiari, but not always. There are a lot of people who live with Chiari without surgery. But if there's surgery, then what they do is they cut the occiput and they make a bigger foramen magnum. Sometimes they do a laminectomy at C1, and sometimes they do a dural patch on the dura to make more space. You want to treat somebody who has Chiari and you're not so sure about it, you should refer. It's possible you might be able to work with that therapist and you could learn what they know. So Chiari is certain techniques are contraindicated for Chiari. Still points, inferior dural tooth traction, cranial compression techniques, OCB platform. Any hand position that places direct pressure on the occiput is contraindicated. This is just to demonstrate where our fingertips are in a platform position. They are adding direct pressure to the area of the herniated cerebellar tonsil. It increases the problem, so we're not going to do it. Of the occipital base techniques, the one that I do use sometimes is the step 4, a spreading of the spreading technique, which I approach transversely. So I do not go directly under the occiput. I go from the side very gently, kind of near where the neck is, and just barely fingertips here. And I do a lateral spread. The intent for the lateral spread, which is on page 72 of one of my study guides, is to spread the occipital condyles laterally and release restrictions in the foramen magnum. So like I said before, compression techniques are contraindicated. When there's Chiari, there's crowding. The last thing we want to do is add pressure into this system. So we're not going to offer compression techniques, and that includes the sphenoid compression and parietal compression. The decompression of both of these is okay and welcomed because it helps to increase space inside the skull. So this is the unilateral occipital, the occipital mastoid release technique, okay, where we put our hand under the occiput and we grab one ear and we're trying to free up the OM suture. In this case, in this particular hand position, you're putting direct pressure on the occiput. So again, I'm going to suggest that you very delicately come transverse under the occiput very lightly and then do an ear pull. It's just a modification. Can make all the difference in the world. If we're doing any kind of traction where there's Chiari, we can approximate that Chiari further down into the spinal column. So we are not going to do any inferior traction at all. So treatment protocols for Chiari, contraindicated. OCP platform is a general contraindication across the board for EDS. Inferior dural tube traction, and any compression techniques. Cautions include intraoral work. Just want to be gentle and watch position of the head. Don't hyperflex or hyperextend, or rotate the neck. So keep it nice and neutral and supported. Sacral release, you want to be careful. You're not going to do the traction piece of that, even though I know that that's dural tube traction. It's a little different than sacral release. It's taught at the same time. So I just want to be clear that the sacral release is okay. Do not do the inferior traction of that step. OCB releases of step 1, 3, and 4 are okay with modifications. I'd actually just prefer that you just not do it at all. Okay. Safe techniques include always direction of energy, always safe. Transverse diaphragm work, including the hyoid. Working distally from the cranium. So you don't have to work on the cranium. You can work anywhere else. A nice TMJ release, any somato-emotional work that you do that you might be trained in, and regional tissue releasing, and that's with caution in a general way. Craniocervical instability and atlantoaxial instability. And symptoms may include headache, a bobblehead feeling, dizziness, GI issues, nausea, breathing difficulties, extreme fatigue, swallowing issues. So this instability compromises the spinal nerve roots of the occiput to C3 and the spinal cord at the C1 to C3 levels, and damage to these levels can result in catastrophic neurological injury, and surgery is often performed to stabilize. We're not going to do anything at all to destabilize this section of the body. The ligaments involved include the alar ligament, which attaches the occiput to C1, kind of in an oblique fashion, kind of like diagonal. So whoops, where's my highlighter? So this is the alar ligament right there, kind of V-shaped. Over here, you're looking at a slightly different manner. It's here. This thing is the dens of C2. It's got a post in C1, which is here, rotates around the dens. Kind of like a peg. Another image of the alar. So it's kind of V-shaped. Stabilizes occiput to C1. And the cruciate ligament is cross-shaped, cruciate. It stabilizes occiput to C2. Okay. And then the atlantoaxial ligament attaches, which is right here, attaches C1 to C2. So these three ligaments are very important, and we do not want to destabilize these. When in doubt, refer out. Contraindicated for craniocervical instability, and atlantoaxial instability. CST techniques. OCB platform, again, general contraindication. Any cervical range of motion testing or mobilization, contraindicated. That includes cervical rotation, cervical flexion, cervical extension, cervical side bend. And also, we do not want to relax the myodural bridge. That might be one of the only structures helping it stay strong. Cautions include intraoral, keep neck neutral. You can still do all the intraoral techniques. It might be really helpful. And dural tube mobilization of the rock and glide. Just going to be very gentle and careful. Watch your hand placement. Okay. The superior hand of the dural tube mobilization techniques under the occiput and cervical spine at the foramen magnum area should just be very, very light. Safe techniques include direction of energy, diaphragms. Cranial techniques are okay. TMJ release, somato-emotional release, if you're trained in that, regional tissue release, and sacral release. Tethered cord syndrome is often found with Chiari. The filum terminale is tethered to the dura. The filum terminale's role is to provide an anchor to the spinal cord, but should allow for freedom of movement of the body. Symptoms may include lumbar and sacral plexus dysfunctions, including lordosis changes, leg pain, weakness, especially walking uphill, low back pain, urogenital and sexual dysfunction, headache, neck pain, may lose ability to walk. So I have known people with tethered cord who are okay for most of their life, and then there comes a point where something happens and their legs no longer work well. Headache, and there's a skin sign at the base of the spine. Okay, a little rhyme there for you. There could be a dimple, a mole, or patch of hair right at the very sacral dimple area. Okay, really low down near the big gluteal folds. Chiari can kind of show up after, tethered cord can show up after Chiari decompression surgery or after cervical fusion. And if both a tethered cord and Chiari are present, both inferior and superior traction of the dural tube is contraindicated. It puts too much strain on the filum to have traction on either end of the dural tube. Okay, so craniocervical instability and atlantoaxial instability is very common in EDS. The symptoms include headache, bobblehead feeling, dizziness, GI issues, nausea, breathing difficulties, extreme fatigue, and swallowing issues. It's just a partial list. CCI and AAI compromise spinal nerve roots of occiput to C3 and the spinal cord at C1 to C3 level, and damage to these levels can result in catastrophic neurological injury. Surgery is often performed to stabilize the cervical spine to the occiput. Now, in treating, if you're in doubt, refer out. Contraindicated techniques include the OCB platform, cervical range of motion testing or mobilization, cervical rotation, cervical flexion, cervical extension, cervical side bending, and myodural bridge release. Cautions include intraoral work, keep the neck neutral, and dural tube mobilization, just be very gentle with the rock and glide. Safe techniques include direction of energy, the diaphragms, including hyoid, all the cranial techniques, TMJ release, somato-emotional release if you train in that, regional tissue release, and sacral release. Tethered cord syndrome can often be found with Chiari. So the filum terminale is tethered to the dura. Filum terminale's role is to provide an anchor to the spinal cord, but allows for freedom of movement of the body. Symptoms may include lumbar and sacral plexus dysfunction, including lordosis changes, leg pain and weakness, especially walking uphill, low back pain, urogenital and sexual dysfunction, headache, neck pain. Someone may lose the ability to walk, headache, skin sign at the base of the spine, which may look like a dimple, a mole, or patch of hair. If both tethered cord and Chiari are present, dural tube traction is contraindicated, both inferiorly and superiorly. In this image, we are showing the sacrum and part of the lumbar spine, along with the conus medullaris, which is the end of the spinal cord itself. And then this thick fiber leaving the conus, going down through the canal, is the filum terminale, and it anchors onto the coccyx. And in tethered cord, the conus medullaris, which is normally ends at about L1, can be drawn down towards or past L3. And then the phylum is adhered into the dura and can also have a bit of thickness or fatty tissue with it. A malposition of the sacrum or coccyx or pelvis may mimic a tethered cord. So if there are any torsions, tilts, rotations, shears, or compressions of the pelvis and sacrum, it may then add all of those aspects and directions into the phylum and cause some of these symptoms of tethered cord. So please check the sacrum and pelvis for any malposition and release as needed. If there is a true tethered cord present, please refrain from dural tube traction. It is contraindicated. Any inferior traction drags pressure from the coccyx inferiorly, and any traction superiorly puts undue tension on dural tube as superiorly. Either way, it's just too much pressure, too much traction on dural tube. So contraindicated techniques for tethered cord include OCB platform, general contraindication. I cannot stress that enough, obviously. And dural tube traction. Cautions include a rock and glide. In this particular instance with rock and glide, just place your hands under the occiput if there's no Chiari and under sacrum, and do not initiate or enhance the motion. Just be with it and wait. Just be with it and wait. It is safe to use direction of energy. It's safe to do transverse diaphragm work, including the hyoid, all the cranial techniques, TMJ release, somatomotion release, if you train in that, regional tissue release, and sacral release, except traction. There's a way to test it, I think. I have a little bit of experience with this. I don't see lots and lots of people with tethered cord. But for those people who I have seen who are sure that they have tethered cord based on medical diagnosis, if I am able to place my hand on the sacrum and just monitor the cranial rhythm, there is sort of a snapping back of the sacrum into a flexion phase. So it doesn't glide as well. It has this quick bounce back up into flexion. I'm sorry, into extension. My apologies. It feels like it's snapping back into extension, okay, instead of gliding. Again, check for malposition of the sacrum and pelvis. So the autonomic nervous system is responsible for all things automatic in the body. And in Ehlers-Danlos syndrome, many people experience dysautonomia, which is a dysregulation of the autonomic nervous system. So things that the autonomic nervous system are supposed to regulate kind of get hosed up, and temperature regulation, tears, sweat, saliva, special senses, cardiopulmonary breathing, sinus rhythm gastrointestinal function, and that sympathetic response to stimuli, the fight, flight, fright, freeze, flail, faint, is in a hyperactive state, and nothing is regulating properly. Coming up with Beyond the Dura, Stephen Porges is going to be on to talk about the polyvagal theory. So that is going to go much more in depth about the autonomic nervous system function. I just want everybody to understand that in EDS, there is dysautonomia, and where we should have rest and digest, instead we have a fight or flight response. CranaioSacral therapy is unique in its treatment protocols that it can help dysautonomia, because it's one of the biggest side effects of craniosacral therapy is regulating the central nervous system and the autonomic nervous system in particular. So with dysautonomia, 3 big things show up: postural orthostatic tachycardia syndrome, gastroparesis, and anxiety. POTS, or postural orthostatic tachycardia syndrome, technically is an increase in heart rate with the blood pressure remaining the same. And then what happens is that the heart has to beat faster to bring blood to the brain, because the pressure of the blood vessels does not increase at the same time. So there's not enough blood getting to the brain, and people will feel dizzy and faint and sometimes pass out. And in those situations, we also want to be concerned about concussion. Other symptoms may include weakness, sense of tremors, bladder dysfunctions, and fatigue. Gastroparesis is delayed gastric emptying. There can be pain, nausea, bloating, early satiety, and you confirm this with a gastric emptying scan, which you eat something that has a radioactive tracer in it. You have pictures taken throughout the day, and they measure how long it takes the food to go from one end of your GI system to the other end of your GI system. And anxiety seems to be very, very, very common in EDS. In my opinion, I think this is due to the structural integrity of the central nervous system. I just don't think that the structures are strong enough to properly regulate the impulses, the nerve impulses. So and also with that hypermobility in that system, it has to be on all of the time in a protective manner. And like I said before, craniosacral therapy is one of the best things to help with dysautonomia, just from the nature of how we work. I told you I was going to talk about mast cell activation for it, just teeny tiny little bit. And this is also very common in people with EDS. It's not fully understood why. It can be very complex. It is a hyperactive allergic response to seemingly benign triggers. So mast cells are part of the immune system, and we typically would see them if we're stung by a bee, and then all these, all of our immune system cells, mast cells, migrate to that area and cause the inflammation and the swelling. But what can happen is in loose connective tissue, one of the theories that I've heard is that the mast cells have no barriers. They just go willy-nilly wherever they want. So people can have repetitive anaphylaxis reactions that almost seem, they're mild almost, but they're still anaphylaxis. And mast cell activation syndrome mimics symptoms from dysautonomia, intracranial hypertension, craniocervical instability, Chiari, anxiety, GI issues. So it's very challenging to suss out what's what and what's causing what symptom. And in EDS, all of these things can be present at once. So you can have mast cell, intracranial hypertension, craniocervical instability, Chiari, tethered cord, anxiety, GI issues. So it becomes very complicated and complex to just try and figure out what's happening. Luckily, There are some dietary changes that can be made and a few medications that can help stabilize mast cell activation. So if that can get stabilized, then the true source of other symptoms may be able to be found. And finally, on to some self-care. I just have a handful of tips for people who are living with EDS. First, I'd like to suggest that you just take care of yourself. You love yourself. You are kind to yourself. This is a body that you're living in. And even though we often talk about our brain and our body as separate things, we are really one and the same. So be kind. Please be kind to yourself. We have a tendency to, be doing okay. And then we get an injury. Suddenly, all of a sudden, that ankle goes out, right? Or that shoulder goes out. And we will first feel this, frustration and sadness, followed often very quickly by anger at the joint. So what we might see is someone who says it's, I've got a dumb ankles or a stupid shoulder. You're talking about yourself. So if you were to hear someone talk to a child like that or your friend like that, how would you feel? How would that make you feel? That is, when you're doing that to yourself, that is what's happening, is that you are causing some hurt maybe to yourself. So I also suggest that when you turn your ankle, when your shoulder goes out, and by the way, I am guilty of doing this, of being hard on my joints, saying my dumb shoulders, stupid shoulders, whatever it is. So I get that. But I've been trying really hard. If my shoulder drops out of socket, I can say, oh, geez, I'm really sorry. Are you okay? And I'll just love it. And in doing so, I am trying to also love myself. There are a couple of exercises you can do when you're feeling that fight, flight, and anger of your body. You can just have a hand on your heart and close your eyes. And you're just going to breathe in slow breath, and hold for 4 seconds and exhale for 4. So you're breathing in for 4, holding for 4, and exhaling for 4. And this count should be 1, 2, 3, 4. If you need a little bit of extra time for inhale and exhale, that's okay. Okay. When you breathe, you should feel a little bit of resistance in the whole process. So it should almost be audible, and you can breathe through your nose. So it might sound like this, or maybe my mic will catch it. Will be that was a little fast. Okay. But also out through the nose, almost like you're whispering it out. I'm not sure you're able to hear me say that. You can do this as many times as you want, but please try and sit with it for about 5 cycles. The next is you can put your hand on your solar plexus, which is just right below your sternum. Breathe in fully as much as you can, and then hold as long as possible. At the end of that breath, at that point where you feel like you have to let it go, instead, take a little sip of air and hold again. You can repeat that a couple more times and then let it out in an exhale. When you do this, be safe, be sitting or laying down, and be logical about this. Okay. If it doesn't feel right, don't do it. If you're feeling dizzy, stop. Okay. This can help improve diaphragmatic breathing and the volume of your lung capacity. And you can repeat this as long as you want, many times as you want. And then the next little piece that I have is that you can put a hand on your heart and or solar plexus, so both at the same time. And then you can close your eyes and connect your mind to the space between your hands. See if you can allow your mind to invite an image of what that might look like. It might not be anything. It doesn't really matter. It's okay if it doesn't show up as anything. Just see if you can feel that space, okay? And then once connected, along that connection, place things that feed your soul. So in my visualization, you can use whatever you want, okay? But when I do this, I kind of think of like a path, and I try and feel my hands connected along that path. And I'll put things there that would feed my soul. And some of that, as a suggestion for me anyway, is like the perfect temperature day. You know, it's 72 degrees, sunny, clear, not too windy, puffy clouds, you know, perfect. It's perfect for me. Maybe yours is a lot different than mine. Another thing that I think about is, you know, like a little baby animal, but that baby animal should probably be totally asleep without sharp teeth biting me or claws, and not having an accident in my lap. So you can put whatever you want on in this pathway. It could be people, it could be your favorite plant, a favorite drink, a favorite feeling, favorite movie, if anything that feeds your soul. Okay. You can do that as long as you want to, and multiple times a day. While you're doing this, you can practice your breathing exercises. Also, you can do this on any part of your body that needs attention. So it's a knee or shoulder, neck, whatever you want. So if you have EDS, love yourself, be kind to yourself, consider holistic self-care. Make sure you're in a support group. If you're a craniosacral therapist listening, make sure you know who your support groups are in your area. Modify your exercise as you need to, but you must do some exercise. Just do it nice and slow and low weights, low reps, nice and slow. Integrate peace and fun into your day. That might take, for some of you, that might take time to integrate, but just take the time to do it. Just do it. Okay. Might take time, but do it. Go out with your friends or have a Zoom call over coffee or tea or favorite beverage of your choice, or a game night, and definitely stay connected to your community. That's very important. And as us therapists, what we can do is we can stay curious, listen to us and our clients, trust us, yourself and your clients, and continue to learn. I am here for you every step of the way if you need to reach out. Be humble, be courageous. Do not be afraid to treat people with EDS. Just be mindful. Here's just a little list of resources. The EDS Society ECHO team is a multidisciplinary teach, all learn program for practitioners. Professionals from all over the world get together and talk about EDS and case studies. It's something you can sign up. For on their website, edssociety.com. There's a group called EDS Wellness, and this is all holistic self-care. EDS Awareness has a great database of all the support groups in the United States. Of course, there's the EDS Society, which is international and has a tremendous amount of information on their website. There are multiple hypermobility podcasts. I think if you probably just searched in the podcast feature of your listening stations and just put in hypermobility or Ehlers-Danlos Syndrome, I think you're going to get more than a handful of resources. There's a site called The Mighty, which is more for rare disorders, but has a heavy EDS spin on it. And then a link for Norris Labs if you want to keep up with some of the research that they're coming out with. I can be found on social media. I have one pretty good group. It's the EDS and CTDs, which is Connective Tissue Disorders, abbreviated, Coalition of Health and Wellness Practitioners. This is open for everybody, practitioners and patients alike. The idea of this group is to try and bridge the gap of two communities. And it's sometimes quiet and sometimes it's not. There's a lot of information that gets shared in general for health. And then, of course, I have a professional page, Connecticut Center for CranaioSacral Therapy, if you want to follow that. And I'm also on Instagram. So this EDS and CTD's Coalition of Health and Wellness is on Facebook. I have a Facebook professional page, CT Center for CranaioSacral Therapy, and an Instagram for my business also, but not for the coalition page. Once a month, I offer a focused study group on EDS. We meet online at 7 o'clock, first Monday of the month. I am trying to hold it every month, but it hasn't been consistent. I'm also available to chat anytime anyone wants to. I also have a podcast that I might be on in a, I don't know, short future. And I am in the process of pulling a book together. So cross your fingers, I can get that out in a little while. So that does it for me. I thank you very, very much